This is LiveWell Talk on how to lower your risk of heart disease naturally. I'm Dr. Dustin Arnold, Chief Medical Officer at UnityPoint Health, St. Luke's Hospital. Joining me today on the podcast is Dr. Ankur Vyas, interventional cardiologist with St. Luke's Heart Care Clinic. We'll be talking about simple, natural steps you can take to protect yourself from heart disease and reduce your risk of heart disease, as well as it applies to cerebral vascular disease as well. Dr. Vyas, welcome to the podcast, your first podcast.
Yes.
I could have swore that we've done one before.
Yeah, thanks for having me.
Yeah, no, thanks for joining me. How long have you been here now?
Almost 8 years.
8 years?
Yeah, like over 7, I guess. It's
yeah.
somewhere between that range, yeah.
And prior to that, you were at Mercy in Iowa City.
Correct.
How long were you there?
I was there for 3 years.
3 years?
Yep. And then, I started there right after my training at the university.
Okay, all right. Well, you've established yourself as a well-respected and reliable, competent interventional cardiologist. We're glad you're here.
Thank you. I'm glad to be here.
Let's talk about heart disease. Take us through what risk factors can I control to prevent heart disease?
Great question. Yeah. So we know there are risk factors for heart disease, and as you said, there are risk factors we can control and factors we cannot control. The factors we can't control are age and genetics, basically. The risk factors we can control include diabetes, high blood pressure, smoking, our diet, exercise. All these things are things we can focus on to try and reduce our cardiovascular risk.
One that I think doesn't get mentioned a lot is quality sleep.
Mm-hmm.
And there are a lot of studies out there. You and I have seen these studies because as a resident and even as an attending, you're up all night, and like how third shift workers have more heart attacks. What's your experience with that poor sleep, beyond sleep apnea? Sleep apnea, they get low oxygen, strains the heart. That makes sense.
Sure.
But just poor sleep.
So I would say it's more a risk factor for increased levels of inflammation, and that is a risk factor for heart disease. So, to the best of my knowledge, that's more the accepted mechanism behind it. The American Heart Association recommends 7 to 9 hours of sleep for most adults. So that would be what's recommended, and so quality of sleep does affect our cardiovascular risks.
I always personally, and that I must not get enough sleep, because when they take away that hour in the spring and then give it back to me in the fall, I'm always so much happier when I get back. So I must not be getting enough sleep. But I think the average American sleeps like 6.5 hours, which when I was younger, I probably could run on that. As I've gotten older, I need 8 just to not be grumpy. But isn't there like a old wives' tale that most heart attacks occur like in the early morning hours? Is that true?
It is. So the rates of MI are higher around that time, statistically by a little bit. You're not talking dramatic changes, but yes. And often it's to do with other things that go on in our body. Our bodies work on a diurnal rhythm. There are neurohormonal changes and other things going on all the time. So I suspect a lot of that has to do with that. There is a diurnal variation. Again, when you are, on studies that basically look at ERs and what times patients show up. Yes, there is a slide. Do we know exactly why that is? We don't. But my guess is that's probably what the mechanisms are. Yeah.
Sleep that knits the unraveled sleeve of life. That's a quote from Macbeth. So sleep is important. Now, it's so easy to throw out exercise. We've had other podcasts about exercise. And I think the main thing that I always stress to people is you don't have to be a CrossFit ultra athlete to exercise. Simple things. But how does exercise reduce your risk for heart disease?
Every study that's been done regarding this has demonstrated a benefit. Exercise is just such a physiologic medicine for everything in our body. It gets the different neurohormonal responses in our body working in a positive way. So it essentially leads to positive effects on pretty much everything it's been studied with. And with exercise, whatever you can do is great. And the more you can do, is better. But it's really about, the recommendations are at least 150 minutes of moderate level activity like walking, or 75 minutes of strenuous activity like running per week, spread out over the week. But really, that's at least. If you can do more, great. And if you cannot reach that due to limitations, either time limitations or orthopedic limitations, just do the best you can. The more you do, the better our bodies do in the short term and in the long term. And plus, there are other benefits as well. We release endorphins when we exercise. It typically makes people feel better, and it affects our autonomic nervous system, improves that in the long term. So there's really excellent benefits of exercise in pretty much everything, that it's ever been looked at.
From my patients that I take care of, mostly an elderly population in the hospital, the patients that are more mobile are healthier.
Absolutely.
Just getting out of a chair, or one thing I always check is grip strength. So you always, shake a patient's hand. It not uncommon for someone that has a good grip, chances of getting readmitted are a lot less.
Yeah.
And it's just simple things. I think it's that mobility.
It is mobility. Actually, there's recent evidence that some strength, or keeping your muscle strength over time, or doing some amount of strength training, is also beneficial in the long term. Like in the past, the focus has mostly been on aerobic activity, but there is recent evidence that even strength training helps. And so a combination of that is probably the best, option. But really, the general rule of thumb is whatever you can do, because
there's three things in life that people are set in their ways and you really shouldn't bring up. One is religion. The other is politics. The third is what type of food to eat. Because people are very set in their beliefs, and it's hard to convince them. But from a cardiology practice, the food pyramid's been inverted, ketos, fasting, Mediterranean. What's your go-to recommendation for diet?
So based on actual evidence and randomized data, the one kind of diet that has been proven to be beneficial from a heart viewpoint is the Mediterranean diet. That is the one we have the most evidence for. And all that means is a diet rich in fruits, vegetables, nuts, olive oil, lean meat or fish. That's the rough food groups that I'm talking about. So that has been shown to reduce the risk of cardiovascular events in people in the long term.
Now, I happen to believe that the ultra-processed foods, that is a lot out there, I think those are really bad for you. So if somebody sees me in a bag of Doritos later today after lunch, I'm not following my own advice. But I really think we're going to discover as time goes on that how dangerous those ultra-processed foods are. I kind of like the simple rule that if you can't recognize what it is, don't eat it. If you can't say, well, that's corn, that's tuna, then don't eat it.
I think that's a great rule.
But I don't always follow it, but I do think it is. In calories in still matter, correct?
Yes, to an extent. Yes. Yep.
I mean, some of the longevity studies have shown that lower caloric intake is associated with longer life.
Correct. I mean, and I think a lot of that kind of comes around to weight and, and all of that as well. But yes, yeah.
Well, the other one that is talked about a lot, and I get this asked a lot, did stress cause this problem?
Mm-hmm.
And you had mentioned inflammation earlier, which chronic stress causes inflammation.
Correct.
What do you tell patients? I mean, it's hard for people to say, well, I'm just not going to be stressed.
I think that's the hard thing. I think it's more about finding, so you're absolutely right. There is a link between chronic stress and inflammation, and there's a link between inflammation and a lot of other, lot of things, including cardiac disease. And so at the same time, I don't think we can really avoid stress triggers per se, but I do think there are strategies available now to try and manage stress, and that is key. I mean, in our professions, in pretty much everything these days, there is a lot of stress. And so trying to find relatively positive ways of managing stress, is probably going to be beneficial for people in the long run.
And there's several apps out there. There's a lot of availability. But exercise.
Exercise is exactly
probably the best.
Is definitely, and it has other benefits as well. But yeah, and as mentioned before, you release endorphins. It makes most people feel better.
Yeah.
There's an actual physiologic mechanism by which exercise makes people better. But yes, there's other ways of reducing or managing stress as well. And I think whatever you can do, however you can do it, is just recognizing that this is there and trying to work on it is really the first step.
You know what I recommend to people? I recommend reading Marcus Aurelius' Meditations, because it has that Stoic philosophy that basically says the little things really don't matter, neither do the big things, right? That in the end, none of this really matters.
Yeah.
So that's one of my go-tos for myself, as well as recommended patients. That I think those meditations from Marcus Aurelius are just they're words to live by.
Yeah.
My favorite one is like, if what you're doing at this time, you fear death less than that, then quit doing it. I mean, if you would willingly die as opposed to get out of what you're doing, then why are you doing it? And I think that's good advice for all of us. What are some, I'm older than you, but there is a time, like when I'm early in practice, that still about half of heart disease presented with a heart attack.
Mm-hmm.
And that's dramatically reduced.
Correct.
Advanced imaging and better access to healthcare. But what are some early signs that someone might be having concerns related to their heart that they may or may not recognize?
So, heart disease is a broad term because it encompasses a lot of different things. And, from heart failure to AFib to like heart artery disease and heart attack. So just coming around to the heart artery disease, which is what most people, associate like a risk of heart disease with. There's two kinds of symptoms to really pay attention to. So for chronic symptoms that occur over time, when you're talking chronic coronary artery disease or even other structural heart disease, it's really symptoms with activity. So symptoms with exertion. And usually these symptoms reliably occur with activity and then resolve with rest. The classic symptom would be chest pain or pressure that would occur with activity and go away with rest. Some people, it can just be shortness of breath. Some people can have pain going up to their jaw or arm, again, occurring with activity and going away with rest. So it's another benefit of exercise. If you aren't active, you'll probably miss early warning signs of these. So if you have any symptoms like that, that's one, that's a time to talk to your regular doctor, seek cardiology consultation. The other kind of symptoms are more of acute coronary syndromes or acute heart-related issues. So and the general rule of thumb is anything severe, take it seriously. So severe chest pain, severe new shortness of breath, severe pain, again, going to your jaw or down your arm, anything that is significant, severe, and not resolving, take it seriously, go to the ER. It is important to recognize signs of heart attack and seek care right away, because if it is a heart attack, the sooner we can identify it and the sooner we can fix it, the less heart muscle damage there would be.
My experience, I'm curious to hear your response to this. My experience has been that women more often have fatigue as they're presenting, that they just don't have the capacity they had previously. And then they tend to quit doing something. Like if, let's say they went for walks, never developed anginal symptoms, but all of a sudden they quit doing it, and you ask them why, I just didn't, feel good. I mean, for me, I think women can present a little bit more sublimely.
Sure. I think there's evidence to back that up, that women do have more atypical symptoms. So again, I think, it's a good thing to listen to your body and not to ignore things. You're absolutely right that sometimes you can just try and avoid things because and not really recognize that the reason you're avoiding it is because you're having issues with it. So.
Also, patients with peripheral vascular disease, seldom do they have symptoms of claudication when you see them, but you really dig through their history and they quit doing what they were doing because of claudication.
Correct.
It's always kind of a sublime presentation. One last question about cardiac, from a cardiac standpoint. Coronary calcium score. That's advertised a lot. You get flyers in the mail, get screened for coronary. How do you integrate that in your practice?
I think that's a great question. I think it's a great tool. I personally use it a fair bit. In my mind, it is best used in people at intermediate cardiac risk, when you want to risk stratify them into either high risk or low risk. So for people with a family history who want to know their own risk, because we have good tools like the ASCVD risk calculators that can give us a population-based risk. But tools like a calcium score can help us individualize it to you. So, so I use it in people who have a strong family history of heart disease. Especially premature heart disease. I use it in people who have hyperlipidemia, who are hesitant about going on a statin. Basically in identifying people who will benefit from more aggressive risk factor modification. And really, the most important risk factor modification that we can do from our end for these patients is put them on aggressive lipid-lowering therapy, like statins. You were saying earlier about how the rates of acute events has come down with CAD. One of the big things is we are getting better at treating people for their risk factors, especially dyslipidemia. So statins have really, that's been, I think, the one change that has really lowered the risk of acute events.
I think you're right. And just much like ACE inhibitors with heart failure, statins with coronary artery disease. But always want to stress people that it's not just your cholesterol level. It's stabilization of that cholesterol plaque.
Exactly. You're
statins.
Absolutely right. So that's what, yes, because so with, if you're looking at the mechanism for heart attacks, they're not, heart attacks are by definition sudden events. They occur because a cholesterol plaque suddenly opens up, forms a clot, and that causes a total or near total occlusion of a vessel. So by definition, it's a sudden event. The vast majority of MIs, of heart attacks, occur from plaques that are fairly mild in severity. Mild as in they're not significant obstructive lesions. This isn't something that slowly progresses over time and gets narrower and narrower and then causes a heart attack. The majority of this, of acute coronary syndrome, occurs from plaque that is relatively mild at that point in time. So this is the reason why, if you look at evidence and look at data, stents have not been shown to prevent heart attacks. They're great at treating heart attacks. They're great at treating symptoms. But this is the reason why prevention is actually about treating these risk factors, because all these risk factors in their own way increase the risk of this sudden change. And this is also how a CT calcium score helps. I would think of it as, the more plaque you have, the higher statistical risk that one of them can rupture. Exactly. And so that's why if your calcium score is high, then it's worth being more aggressive. And with statins, you're absolutely right. It's not just about lowering the cholesterol. That's only part of it. In fact, the bigger mechanism by which they reduce cardiovascular risk is by stabilizing these plaques. That's the main way. This is the reason that there's other medications that we used to use in the past, niacin, all these other things. We don't use those anymore because even though they may lower your LDL, they've never been shown to actually reduce hard endpoints, which means risk of heart attacks, strokes, or cardiovascular death.
Okay, I'm going to throw in one more question. This is more for my practice. Aspirin for primary prevention. Here's how I've approached my patients. Mm-hmm. If they already were on it, I've kept them on it. I just haven't started it for primary prevention. What's the cardiology world doing?
I think we're mostly doing that. I still, so it is not necessary to put most people on it for primary prevention anymore, because there's good evidence now that there is no net benefit of it. And by net benefit, I mean if you combine the small ischemic benefit versus the small increased risk of bleeding. So I take it case by case. Most people, if they are not at increased risk, I tell them they don't have to take it. They can safely stop it. For patients who I believe might carry an increased risk of bleeding, like the elderly, I tell them to just go off it. Because I think in that case, the risk might not be worth the benefit.
Yeah. I guess I've been approaching the philosophy they haven't any bleeding problems.
That's true.
Do you remember the DIDGE study where it said digoxin, if people are already on it and you stop it, they do worse than people that aren't on it, put them on it, they don't do any better. So I was kind of like, well...
I think actually that's a good way of thinking about it, because if they haven't shown any evidence of bleeding so far and they've been on it for a while, they probably fall in the category where they have a lower bleeding risk and might still get a little bit of benefit from it. But,
I always like to probe the guest on this podcast about the way I do things so I can feel good about myself. Because, One last question. Why cardiology?
It's something I connected with as a med student, as a resident. It's just, so that's part of it. I have a family history of heart disease. So that's the other part of it.
Well, we're glad you did connect to it because you've done a great job. Dr. Vyas, thanks again for joining me and sharing with our listeners about how to lower their risk for heart disease naturally. Once again, this is Dr. Ankur Vyas, interventional cardiologist with St. Luke's Heart Care Clinic. To learn more, visit unipoint.org/CRHeart.
Thank you for listening to LiveWell Talk On. If you enjoyed this episode, don't forget to subscribe. And if you want to spread the word, please give us a 5-star review and tell your family, friends, neighbors, strangers about our podcast. We're available on Apple Podcasts, Spotify, Pandora, or wherever you get your podcast. Until next time, be well.